This is the lecture on social suffering, inequity, and violence. I want to start this session by referencing the work of several anthropologists, Kleinman, Dawson, Locke, who put out an edited volume in the late 90s on the subject of social suffering. And I want to use some of their broad ideas about what social suffering is to frame this lecture and to look at the particular cases that you read. So when these authors talk about this concept of social suffering, they're talking about something that has a few characteristics. First of all, it's the idea that experiences of, expressions of, and responses to suffering are social. So it's taking suffering out of the sort of individual realm and thinking of it as something that has a social context and that is experienced socially and frankly caused socially. The second thing is that it is social forces, particularly political and economic forces, that produce the conditions and tendencies for many forms of suffering to occur. And hopefully at this point you're also seeing resonance between this set of ideas and what we talked about when we talked about global health, right? Very similar kind of framework for thinking about where illness and more generally where suffering comes from. You have some examples, we'll talk about these a little bit more in a few moments, of exactly how political and economic forces produce suffering. So, for example, you read about Paul Farmer's discussion of the widespread incidence of tuberculosis in Russian prisons and sort of how that happens, what the social context is for that to happen. Also, Hamdi's work on kidney failure in Egypt. And then, of course, Ansell's work on what he refers to as the death gap, right here in Chicago and elsewhere in the world and in the U.S. And then the final point that is captured by this concept of social suffering is that representations of suffering also matter in terms of how we think about what suffering is and how we respond to it. And I want to talk about a couple of kinds of representations of suffering that I think are important in this way. The first is uses of statistics to try to capture suffering and what the implications are of using statistics in that way. And the second is media representations of suffering. So we'll look at a couple of examples of those. So to this idea then that social suffering is a way of thinking about suffering as produced by a range of political and economic forces. One of the cases that you read about that illustrates this really clearly is Paul Farmer's work on TB in Russian prisons. Paul Farmer is one of the sort of better known anthropologists. He has been sort of quite visible in the public realm. He's both an MD and a PhD. He's been particularly active in Haiti around health there and active with an organization called Partners in Health. So you may have heard of Paul Farmer before. So he's one of those very prolific people who has both published a ton and is very active as a doctor and as a sort of public critic. So in this particular piece, he's talking about all the things that lead to widespread tuberculosis in prisons in Russia. And one of the statements he makes in that article is that, and he's talking about a particular patient here, is that Sergei's lungs have been destroyed by the tubercle bacillus, which is that element that causes TB. But this is only the distal event in a long and complicated story. So he's trying to get us to sort of zoom out and think of TB as not just, and maybe not even primarily being about infection with TB. It's about all the things that lead to that eventuality. So what are the things that lead to that eventuality? Well, we can almost look at this as sort of a flow chart. So there's increased poverty and increased crime in the context that he's talking about in Russia. What that leads to is more people being detained for these crimes, and detained in spaces with very poor health conditions. There's a lack of food, there's not cleaning, and people are close together in small spaces. That leads to an increase of the spread of TB, right? If even one person in one of these prisons has TB, it's spread readily to other people. Because there's also then inappropriate or less than complete treatment for TB in the prison context, because there's not really resources, there isn't really a a real attempt to wipe it out, and there's resistance, then it continues to spread and the problem continues to grow. So then you have drug-resistant TB infection, right? So then it's all the harder to treat. And there's no treatment for it. And that leads to cases that they simply can't do anything about. They become classified as untreatable. And then those individuals either die or, in fact, are released. And although this is considered to be a humane thing to do, to release people on these grounds, in fact, what it does is it infects the family members of those individuals and leads it to the wider society. So then you have this sort of cycle of people moving in and out of prison spaces and widespread tuberculosis, which incidentally is a disease that in many parts of the world has been eradicated. So the overall message here is that this epidemic of incarceration has led to an epidemic of drug-resistant TB. So again, we have a health condition, we have a disease that is not just about the biology, but is also about the social context, and in this case, the particular criminal justice system. Another example that also illustrates this is Hamdi's article about kidney disease in Egypt, and particularly dialysis patients, poorer Egyptians seeking out and receiving dialysis treatment. And again, not unlike what we see in the Farmer article, Hamdi is pointing out the causes of suffering for these patients that go beyond simply the fact of their kidney disease. So what are some of those causes? Well, there's the fact of corruption within the hospital system and within the state more generally. There is mistreatment within medical care. There's pollution, which people understand to be central to the cause of their kidney disease in the first place. So when Hamdi interviews these dialysis patients, what people are telling her is that they see these parallels between what's going on in their treatment and what's going on in the Egyptian state. They see the breakdown of their kidneys, of their actual bodies, and these sort of not very well functioning, not very well maintained dialysis machines that are also breaking down as directly related to the breakdown of the state, which is not able or willing to care for all the citizens of the country, particularly the poor. And then you also read the Ansel book, or an excerpt from the Ansel book. This book is called The Death Gap, and it's a really interesting read. If you were interested in what you read in the excerpt that I gave you, you might consider reading the entire thing. David Ansel is a doctor who has worked for several decades in Chicago, and is really familiar with what illness and healthcare looks like in a really inequitable American city. And that's what he's talking about here, is the ways that the socioeconomic circumstances and the socioeconomic stratification in Chicago leads to radically different health outcomes for different sectors of our population. Where you live in the city has a significant effect on what kind of health you will experience and what kind of care you will or will not receive. And therefore, literally your life expectancy is informed by that. So this death gap that he's talking about is literally the difference in life expectancy for people on the south and west sides of the city versus those on the north side. That it's that stark, that there's significant difference in how long people live because of the difference in their healthiness and their access to care. He starts this piece that you read talking about how clearly there are two Chicagos or two Americas, and that is in terms of both people's health and their access to health care. And he's suggesting that this is not about differing biologies or people making different choices. This is directly a result of socio-political conditions. These are human-made circumstances that lead to this difference. He highlights the life of one of his specific patients, Windora Bradley, and it shows through his discussion of her life and death how all those different inequities play out. That there are effectively built-in constraints on her health because she is poor, because she's African American, and because she's living in a poorer part of Chicago. So there are, in fact, deep-seated health issues that are tied to those issues of socioeconomic difference, and neighborhoods where there is simply just a lack of health care. So again, health is not just biological, but it's affected by all of these factors, which he refers to as structural violence. Structural violence is all of those inequities that he points out as embedded in daily life in the United States. That those social fault lines that run through U.S. society condition people's health, and that includes their life expectancy and the illness or wellness they experience during the course of their lives. So in other words, when Dora Bradley, who dies in the end of a stroke, that is not just a result of what's going on in her body in that moment. He suggests that the causes of that stroke include social forces such as racism and economic deprivation, which are embedded in the laws and policies of the United States more generally and in Chicago as well. So again, that leads him to his sort of central thesis, which is that there is a death gap, that life expectancy is one of those markers that we can use that sort of encapsulates various kinds of health inequities. He makes a comparison between the life expectancy in Haiti, a place where people suffer from poor health and lack of access to health care, versus the United States. It's a stark difference, right? It's about 63 years versus about 79. But what he suggests is, in fact, there are bigger gaps within the U.S. than that gap between Haiti and the U.S. That there are gaps in life expectancy as big as 30 to 35 years between different segments of the U.S. population. And that death gap is growing, right? This is not a difference that we are successfully closing, quite the opposite. And it's particularly hitting certain folks, African Americans in urban and rural high poverty areas. So all of this that Ansel's pointing out is a suggestion that we need to think differently about where health originates from, and it needs to go beyond just biology and behavior. That is, we need to understand how structural violence conditions people's well-being, and distinguish between those immediate causes of ill health and the chronic structural causes of disease, which are not always as obvious when you're looking at an individual patient, but become much clearer if you look more broadly across a larger segment of the population and over time. So the third sort of component of the social suffering concept that I started off this lecture with is the notion that representations of suffering are also really instrumental in how we imagine what suffering is and how we respond to it or don't respond to it. And as I said, there's a couple of different examples I want to provide for different sorts of representations of suffering and the effects they have. The first of those is statistics. We've all seen lots of sort of statistical analyses or representations of relative well-being in the world. One example that I want to show you and lead you to is something called the Human Development Index, which was developed by the UN as a way to think about differential well-being across the world. I've included this link on D2L, so you can also find it, because as you may have noticed, or if you haven't, you will shortly, you have a discussion where I've asked you to contemplate the difference between these sort of statistical approaches to characterizing human well-being versus the kinds of accounts that you are reading in this course, ethnographic accounts. So this Human Development Index literally ranks all countries in terms of sort of level of well-being of its citizenry. So it takes a variety of factors, including things like life expectancy, how many years people are able to go to school, the gross national income or the per capita gross national income of people who live in that country, etc. And there's a variety of factors, and then it uses all of those factors to sort of boil it down to one number. And that's sort of a perfect score would be a 1. So it's all sort of in percentages of 1. So you can see here the top, the country with the highest, this is the 2020 index, they do it every year. The highest human development index, according to this particular formula, in the year of 2020 was the country of Norway. So you can quickly see sort of who's at the top, and if you scroll down through this list, you can see who's at the bottom. And these factors are considerably lower. And you see, again, we've already talked about life expectancy as one way of capturing sort of people's healthiness or lack of health over time are right there. So again, this is something you're going to be working on as part of your discussion. And what I want you to think about for this is, what does it do for us or not do for us to try to capture human suffering in this sort of statistical way? In what ways does that clarify what's going on in terms of global suffering, and what ways does it hide or obfuscate things? And how might you go about comparing those kinds of statistical representations of social suffering to the ethnographic accounts that you read by people like Farmer and Hamdi? So again, I'm just going to throw that out for now as a thought question, and ask you to write about this in the discussion that you will be responding to on this subject of different kinds of representations of suffering. The other sort of representation of suffering that I want to touch on is media representations. And in that volume that I mentioned at the top of the lecture that's called Social Suffering, which it brings together a whole bunch of anthropologists to talk about this concept, one of the pieces is by Arthur Kleinman and his wife, so that's the other Kleinman. They're both anthropologists, where they are talking about the role of media imagery in how we think about what suffering is. And they use a very specific image to focus their discussion. It's a photo from 1993 by a photographer named Kevin Carter, and it was taken in the context of a famine in Sudan. And I'll show you the image in a moment. It's quite disturbing, but it is an image that they chose because they are arguing that that image is a good example of the ways that images of suffering are appropriated by the media and consumed by the public. And they're asking, what are the moral implications of that? What does it mean for us to be looking at images of suffering commonly, in fact, daily? If you follow the news, there is a lot of that. Is that enlightening us and making us more responsive to the suffering in the world? Or does it desensitize us and make us less likely to actually think of this as something that we need to act on? These are some of the questions that they're raising. So this is the image from 1993. It's a young girl in the context of famine, clearly malnourished, on her way to a feeding station. You would not know that she's on her way to a feeding station because this is how Carter framed this image, with the, of course, sort of ghastly image of this vulture looming over her. Clearly a disturbing image, one meant in a certain way to shock, but the responses to Carter and this image, I think, again, say something about the questions that Kleinman and Kleinman are trying to raise. So they analyze the effects of the photo. What is this photo saying? How is this media image representing suffering? There's a message of helplessness that this this tiny child is in need of outside assistance. So there's something sort of paternalistic about it. Also because it's set in Africa, and all of the sort of legacies of colonialism and racism come to bear on the depiction of helplessness on the part of this African child. It's decontextualized, right? We don't know where the child is. It's hard to imagine how the child is that close to the vulture without an adult being nearby. It individualizes the suffering of that child. So there's sort of, in the way the photo is framed, right? This is Carter's choice to do this, but it's also the choice of the New York Times to publish a photo framed in this way. There's no community or institutional context. It sort of naturalizes this moment of suffering. It also, Kleinman and Kleinman suggest, appropriates suffering as a sort of entertainment, a sort of, I don't think they mean entertainment like people think it's a fun thing to look at, but more that it's something that is gratifying in allowing people to see something very dramatic, right? And that there's some element of entertainment in that, right? It's a powerful and sort of almost the kind of photo that really catches your attention, captures your attention. That is partly why it was published, and that's the way in which it is entertaining. And it also, they suggest, Kleinman and Kleinman suggest, it's the kind of image that puts forward a stance of superiority. It's a sort of neo-colonial image, right? Again, suggesting that this individual child or people in this setting need, quote unquote, help from someone else, help from the West, typically. And it also is distancing, it's othering, right? They argue that it's desensitizing, that it does not draw the viewer in to think how they might engage with this particular set of problems. So overall, Kleinman and Kleinman are suggesting that images, including especially images of suffering that we see through the news media, are not passive, neutral reflections of events, but that they actually actively participate in producing suffering as a cultural category. They are the things that inform what we think of as suffering and how we frame policy and action. Carter, the photographer, received a Pulitzer Prize for this particular photo and also received widespread criticism. There was a lot of backlash against it. And there's a lot more to say about Carter, who had a sort of fraught life and career. But again, Kleinman and Kleinman bring up this particular photographer in this particular photo, not to focus on him in particular, but as an example of a much broader trend, they suggest. So this unit is about social suffering that arises from inequities of various sorts, and we've focused so far primarily on health inequities. But violence is entwined with a lot of the kinds of things that we've been discussing, and I want to zoom in on that a little bit now. We've already talked about what I referenced as the violence continuum earlier in the course, and the different kinds of violence that come to bear on people in the world: structural violence, symbolic violence, and political violence among them. So the other pieces that you read in this unit really look at violence as a source of people suffering, right? So health being affected by violence, and particularly in places where, or in elements of violence that are widespread and embedded, right? So not individual random acts of violence, but places where violence is part of people's everyday experience, and that experience passes across generations. So I think what these readings demonstrate is that experiences of violence end up informing cultural understandings or worldviews. They become part and parcel of the framework through which people view the world. And they are indeed, that framework is passed across generations. And that the ways that people experience and categorize the effects of that violence are not always captured by biomedical attempts to treat them as illness. So we'll talk about a couple of examples where the biomedical category for the trauma of violence is at odds in certain ways with how people actually experience that trauma on the ground. So you read two pieces that I think have quite a bit in common, even though they're set in really different parts of the world. And they're precisely about that, the effects of political violence across generations. And when violence is sort of thoroughly saturated a society, right? How do people process what that means, and how do they move on and sort of try to get along despite all of the trauma that remains? So the Dixon Gomez piece is one of those, and it's about how violence and experiences of trauma are transmitted across generations. Okay, so Dixon Gomez starts with the sort of general understanding that violence and the ways that people express their trauma are always culturally mediated. Right. This is not just an acultural psychological response, that there's a cultural way in which people talk about or act on or experience things that they have gone through, okay? It's not separate from culture, it's embedded in culture. And in the particular context that she's writing about, which is El Salvador, what she found is that the older generation transmitted their experiences of trauma to the younger generation through what she called a sort of a traumatized worldview, that the younger children who had not experienced war were socialized into that worldview. It happened in all those sort of everyday ways that culture is transmitted. Children overheard conversations about it. There were stories about the war that the older people told, and children were sort of imbibing those stories and that perspective. Children were taught to distrust politicians, their neighbors, etc., and to expect violence to a certain extent, because that had been the experience of their parents. There was also a sort of local illness category, nervios, which was a way that those who had experienced the war communicated their loss and grief. But it also called on the younger generation to act as caretakers. And so again, it brought them into this sort of set of meanings and this worldview about trauma. PTSD is the sort of the Western psychological illness category usually used to talk about trauma. And it was deployed in this setting as well. But one of the points that Dixon Gomez makes is that PTSD, as it's typically understood in psychology, is not the same, or it did not really fully capture what the Salvadorans who went through these experiences during the war were going through, okay? PTSD is usually framed as something that is sudden, whereas the Salvadoran experience was one of chronic trauma, again, passing even over generations. PTSD usually is focused on sort of a particular aspect of life experience, whereas the trauma that the Salvadorans were experiencing was really about structural inequalities. So it wasn't just about the war, it was also about poverty and various other elements that, again, were experienced in an everyday way. It wasn't something that was an episode of trauma, it was something that was part and parcel of everyday life. And then finally, PTSD is usually understood as being something that is an individual phenomenon. It's something that attaches to a person, whereas the trauma that Dixon Gomez was describing is population-wide. And then Meinert and White are talking about a different place, but some similar themes in terms of a place where people have really had widespread experiences of political violence. This is in Uganda. And Meinert and White are working with people talking about sort of the after effects of broad experiences of violence. And what people are telling them is that the effects of the war are perceived as sort of a contamination, almost like an alien force that has intruded into everyday life. And that has particularly intruded into the lives of particular individuals who experienced significant trauma. So making sense of what they refer to as these things, that these things being all those terrible things that happened during the war, people use various kinds of explanations. So it's not just one, but there are sort of a few different categories that people go to. One is this set of vengeful spirits of the dead called Sen. So in some cases, that is understood as the cause of the lingering trauma that people experience. The category of PTSD is also in circulation there, just as it was in El Salvador in the other article. And then there are also a variety of other kinds of evil spirits, often grounded in Christian and Muslim traditions. Meinert and White focus on the case of a particular individual named Peter, and the sort of explanations that both he and his family members come up with. And again, they draw both on the concept of PTSD and the concept of these vengeful spirits as being the causes of his ongoing violence and disruption in his life. These Sen spirits, importantly, are really not just about an individual being affected by spirits, but also about a rupture of the social order in terms of the way that the dead are treated. It's very common in many places in the world where political violence has taken place and people were not able to be buried properly, or death rites were not, it was not possible to conduct death rites as they would normally be. That there's this sense that there's this ongoing thing that hasn't been resolved. And it's not uncommon in those places for people to understand those improperly buried dead to come back in a spiritual way. So again, in the case of Peter, then, this is a broader social problem and a family problem, not an individual problem, right? So again, we have a psychological category like PTSD not quite capturing how people are experiencing and analyzing those cases of trauma-caused illness in the local setting. And then the final thing that you read is the piece by Sweet. So this is set in the US, and it returns to the concept of medicalization, which we've talked about several times throughout the course. That being, again, social problems that are categorized as an illness, right? So it's taking something out of its social context and kind of biologizing it, if you will. In this case, Sweet is talking about that medicalization taking place around domestic violence, right? She's charting the nature of treatment and response to cases of domestic violence, and what she's noting is that it's moving in the direction of being understood as a sort of individual illness that can be treated, as opposed to a broader social problem. Abuse, then, domestic violence, for the folks who experience it, is treated as an individualized chronic condition, right? So again, it's more like a medical problem than like an interpersonal or social problem. And that biomedical response, she suggests, has effectively depoliticized domestic violence in terms of how it's understood and the advocacy of supporters of those who have experienced domestic violence. So in other words, there's been a shift in terms of the sort of causal explanation for how to think about and respond to domestic violence. From the feminist framework of thinking about patriarchy or about gender relations or about power dynamics to a more biomedical framework that thinks about domestic violence in terms of risk, right? So she's saying the decontextualization and depoliticization of domestic violence has really done a disservice both to the people who have experienced it and to really trying to confront that problem. It's also been degendered, right? So it's moved from being primarily something that is experienced by women at the hands of men to being something, again, that's treated in a more sort of neutral way as something, again, more akin to a medical condition. So again, as with the previous two articles that we were talking about, this is really about how medical categories are often projected onto complex social and political phenomena and don't always capture all the dynamics. And that is something that often is revealed through research approaches such as those that are conducted by cultural anthropologists. That an ethnographic approach can capture some of those details and cultural meanings in a way that fields like biology and psychology cannot. So we'll end there our discussion of social suffering. I hope you enjoyed these readings, and we'll talk again soon. Bye-bye.